Hi, I'm Desiree Chappell. Welcome to Top Med Talk. It's Tuesday, and it's time for my Roundtable. The Roundtable is a chance to sit down with a multidisciplinary group to have discussion about perioperative care and improving the quality of what we do every day.
Top Med Talk.
Now, my name is Desiree Chappell, and I'm joined this morning by Professor Monty Mythen of Top Med Talk, and we have very special guests with us, Mr. Eric Schneidewind, the president of the AARP and the keynote speaker, and Dr. Kevin Bozic from the University of Texas and the Dell School of Medicine. Now, he is the chair of the Department of Surgery and Perioperative Care and professor of orthopedics. Gentlemen, thank you so much for sitting down with us for the roundtable discussion this morning. Now, we're going to take this opportunity to discuss specifically at this discussion this morning, patient-centered care, shared decision-making, and both of you said this during your presentations, ultimately, outcomes and what matters most to the patient, that's what determines the outcome. So that's what I want to focus on today. I'd like to give you the opportunity for you guys to introduce yourselves and just give us a little bit of background about what you do and why you're interested in value-based care.
Well, thank you for having us. My name is Kevin Bozic, and as was mentioned, I'm a chair of surgery and perioperative care at the Dell Medical School at UT Austin. I'm an orthopedic surgeon, and I have, throughout my career, really tried to gain a better understanding of the impact of what we do in the healthcare profession on our patients, and I was frustrated by the types of tools that we were using to measure that, process measures, structural measures, and those are not things that resonated with my patients. As an orthopedic surgeon, my goal is to improve the health of the people that I treat by optimizing their quality of life, reducing their pain, and improving their function. And I learned early on that the only way to improve those is to measure them and measure them rigorously in every patient and every encounter. And so I've been on this journey now for about 15 years and have been through the evolution that's occurred in this country, and I'm very optimistic and enthusiastic about the direction it's going, especially with conferences like this and being able to attract a multidisciplinary group of people from the AARP, from patients to providers of different disciplines and payers to really come together around this goal. Because ultimately, I believe that for all of us, no matter where we sit, all of us in healthcare, our goal is to optimize the health of the patients that we come in contact with.
And Eric, can you tell us a little bit about what you do and why value-based care matters to you?
Well, I have the privilege of being the volunteer president of AARP, and I serve on the National Board of Directors, and my position gives me the great pleasure of going out and meeting our members and the communities in which they serve throughout the country. They're just a great group of people who really want to make life better in a variety of ways for people, not only those 50 plus, but their children in particular. So we work on programs, and at the health sector, we have a view that I think I can summarize as saying that obviously the healthcare system is incredibly important. Health outcomes are important. But we think that our members many times, have a view that they're not getting exactly, what they want. Many times you go into healthcare and the question is, should you have an operation or a procedure? But our members really tell us that they want health so that they can do something. The famous example, a woman said, I want treatment so I can dance at my daughter's wedding. I want to be happy. I want to be fulfilled. And so to do that, what AARP is finding is that there are a number of practical measures that we can push for. We can't do everything. One of the measures is people benefit from having a health professional who works with them, helps them navigate through the health maze, get them the things that make their life better. That may not be a doctor. It may be a nurse practitioner. It may be a nutritionist if they have a nutrition problem. So let's configure the healthcare system so that those skills are available to people that may be more effective for them than some medical procedure. So we push for expanded scope of practice for nurses and nurse practitioners. We hopefully support plans which take a look in the range of healthcare services provided. Take a look at issues like isolation. Take a look at people who are depressed. And maybe by dealing with something like that, dealing with the hearing loss, you will drastically minimize the number of health issues they have, and in many cases for a great deal less money. So AARP is looking at what the members want, and they tell us that they want issues looked at that may be outside the normal range of medical practice, but that would make their life better. And then we go into the arena of policy, both federal and local, and try to get those measures included in healthcare.
I wanted to just follow up on a point that was just made that if you look at what we in this country spend on social services, it's about average, it's about the median for OECD countries, but it's disproportionately spent on care and health care as opposed to other social services which we know heavily influence health. And so our model in Austin is we really are truly trying to improve the health of the community that we practice in. And in order to do that, we realize that only about 10 to 15% of someone's health is influenced by the care they receive from healthcare professionals. So it requires interaction with educators, with other types of social services. It requires safe places to live. It requires a healthy diet. There's so many other things that play into socioeconomic status, education, that we understand that thinking and isolating care as the primary tool to improve health is not very effective.
And that's exactly what we believe, and what has been so stimulating about this conference is that you have highly skilled medical professionals who recognize that the full range of services can be far more effective collectively than individual ones. And this seems to be going mainstream by some, I must say, very eminent people in the fields.
Monty Mythen here from the UK, from University College London, but also have an adjunct position at Duke and used to work there, so I have a transatlantic view. Kevin, you mentioned something in your talk earlier about evaluating patients preoperatively, and if I understood it correctly, there were sort of 4 categories, going from a reluctance to engage in your own health through to full engagement in your own health. And I think you implied the fact that you didn't think if people were scoring at the lower end of the spectrum, they were ready to enter a surgical pathway, which I fully applaud. Did I hear that correctly?
Yes. So we use something called a patient activation measure, which is a scale from 1 to 4 that is essentially a measure of someone's propensity to engage in healthy behavior. And that's part of our baseline assessment, along with physical function, mental health, quality of life, and healthy habits. And we can tell right up front if someone comes to us and does not have a propensity to engage in healthy behavior, they're not going to do well with us forcing treatments on them. So we want to engage them, bring them into the fold, help them understand what their responsibilities are and how we can help them. But we can't help someone unless they are first willing to engage and be an active participant. So I think it's a critical measure. And I think that a lot of the things that we measure around when we try to optimize risk factors for patients, whether it's for cardiovascular risk or surgical risk, whether it's smoking cessation or weight loss or diabetes control, I think those are all just measures of activation. And the more activated patients are, the more likely they are to achieve health.
Maybe to switch gears just a little bit, talking about outcomes. And we just said earlier, what matters the most to the patient. I think as I travel around and talk to different providers and facilities, there's a lot of discussion about outcomes and its length of stay and cost. And so how do we transform? How do we actually make that change with the providers and the healthcare system to start looking at that? Because it's one thing to say this is what we need to do, but how do we translate that into what we do on a daily basis?
So this is a question I frequently get asked by providers, that what you're talking about, measuring outcomes and understanding costs, is expensive. And the answer is yes, it is. If you look at, in a fee-for-service world, we spend a significant percentage of our overhead on revenue cycle management, right? So we measure everything that we do to patients. Every time we spend an enormous amount of time looking up ICD-10 diagnosis codes, documenting CPT codes, whether it's for ambulatory visits or for surgery. None of that adds value to patients, but it's a cost of doing business that we accept. It can be 20, 30% of the total cost is that revenue cycle management, and then tracking down those bills and resubmitting them and managing that whole cycle. And again, none of that adds value to patients. as we transition to a payment system that incentivizes value, now my business intelligence is understanding my outcomes and my costs, because now that's going to make me more competitive in a value-based healthcare world. So just as I had to purchase revenue cycle management software in the past and use that in the fee-for-service world, in the value world, understanding costs and outcomes is the business intelligence that's going to make me more competitive.
You said something interesting during your talk today, that when you first start transitioning to the value-based care model, it actually can cost a little bit more on the front end. And what do you usually tell providers and people about that?
Again, that's the upfront investment to, you wouldn't, in any other business, you would not start a business without understanding the product that you're providing or the service and what it costs you to produce it. But in healthcare, we haven't had to do that because we weren't paid based on outcome. We were paid based on utilization and time and intensity of services. So that's just the basic building blocks. That's the table stakes to be able to compete in value-based healthcare. But there is an upfront investment, and when you're in the world of straddling fee-for-service and value, you can only amortize that investment on the value side. And so that's why it's incumbent on all of us to quickly push the payer community towards value-based payment to rationalize those investments.
And I know, gentlemen, both of you are involved with policy making. How do we go about this from the top-down approach? I mean, what do we need to be talking about?
Well, I think right now the federal models are starting certainly to have trials. I think Medicaid has really shifted pretty radically over toward managed care models, which incorporate many of the features, although not all, Dr. Bozic mentioned. I think many of the Medicare Advantage payment mechanisms are structured in such a way that they could accommodate these things. And it's my understanding that many of the healthcare systems throughout the country are moving over to this model as well, and we would hopefully support those if they need support. But the market, in many respects, is starting to move, from what I understand, and there are others here who may have more information. So I think what our role can be is at a policy level to convince through scholarly papers and political presentations, Congress, state legislators, that looking at these other issues like nutrition, like loneliness, like depression, these sorts of things can yield gains in terms of the satisfaction of their constituents, but also hopefully some cost gains as well, or some economies. That's the kind of thing that AARP, I think, can do well and has done.
And I'll just add to that by saying that I do believe the federal government has been a leader in transitioning to value-based payment incentives, and both in the Medicare and the Medicaid programs. The other role of the government, I believe, is in the policy world is mandating outcomes measurement, and so support of measuring outcomes through clinical outcome registries, as well as making that information transparent and available to all those who need it to make decisions.
Absolutely. Well, again, we are here today in Newport, California for the Interdisciplinary Conference on Value-Based Care. And I wanted to talk to you guys about something about that patient-centric care and really shared decision-making, because we hear that term so much, and I don't know if as providers we're really grasping what that truly means, because it's, I guess, from what I took from both of your presentations, is that you can tell somebody what their risks are just based on the general population, but am I actually talking to you, Kevin, about your risks? So can you talk
I'll
to
answer.
that?
I'd be very interested in Eric's answer as well. I've been interested in this field of shared decision making for about a decade, and I had a grant from Robert Wood Johnson Foundation in around 2010 to study this. And what I learned when I first started getting into this field was I thought that shared decision making meant that I give my patient a bunch of information about their condition and make them really smart, and then help them make a decision, and they come and share with me their decision. And what I learned pretty quickly was that I'm never going to make my patients doctors, so they're never going to have the depth and breadth of knowledge that I do about the pathophysiology of disease and the treatment alternatives. That said, I'm never going to be an expert in what their preferences and values are. They are always going to be the expert in that. And so what I think the magic of shared decision making is bringing together that asymmetry of information, my knowledge of the condition and the treatment alternatives that I share with the patient in a way that hopefully they can grasp some of it. And then their knowledge of their preferences and values and why they're coming to see me in the first place. I'm always amazed that I see people that say that they recommend someone have a surgery based on a CT scan or an X-ray or something else, and unless I understand the patient's preferences and values, what they're even trying to achieve, it's very hard for me to make a treatment recommendation. So that's where I see the real beauty of shared decision making.
Eric, can you speak to this? Because what does that mean to your membership?
Well, let me give an example that's a little bit outside the envelope of the conference, but relevant, I think, and that is patients who need long-term care upon discharge. Now, maybe for medical reasons that are a result of a surgery, but on the other hand, maybe because of cognitive issues, dementia, that sort of amnesia. The current mechanism in the federal government for supporting people who don't have the means to pay for long-term care is to default to nursing homes and then pay for them at a very, very high cost. Yet what we know, every single study we've done shows that what people want to do is go back to their home, and if they do that, they can, in many cases, in fact the majority, they can live in that home with a cost of support that's far less than the nursing home. Some person who comes in episodically to take care of perhaps feeding or cleaning or that sort of thing, but not 24 hours a day. So we know the patient wants to go home. We know it costs less. They'll probably be healthier. Why isn't this happening? Well, politically, most states default toward this nursing home model. So what we have tried to do at the state level is to change that default, to start allocating more funds to what the patients truly want, in the knowledge it will cost less, they'll be happier, and it's a good outcome for everybody.
Monty, can you actually give us the UK perspective on that?
So a few takeaways from me from this morning, one of them from Eric in particular, I've written down here, is just remember to ask the patient not what is the matter, you should ask them what matters to them. So, if my knee hurts, does it matter to me that my knee hurts, or am I worried about my quality of life and the impact of my knee, or is it my general health? Now, I think Kevin, and you get a comment from you in a second on that, Eric, you said me only about 1% of surgeons in the US really know those outcomes for their joint replacement surgery. Is that right?
Yeah, we don't, as a profession, we don't methodically and systematically and rigorously measure pain, functional status, quality of life, of which there are validated measures to do that. It's generally seen as a research tool and something that's used in a research setting, but not in a clinical setting the way I described it in here. I absolutely agree with that comment about, we like to say that, instead of asking after the visit, how were we? There's a lot of people who survey their patients and say, how'd we do? How were we? It's not about how was we. How are you? How are you? And is your health better after this interaction than it was before?
So as you know, Kevin, because I know you've got friends in the UK, we have this patient-reported outcome measures scheme. So I was just looking up the results from the last quarterly result, and 70% of patients completed it who had knee replacement surgery in the NHS. Now, the good news is, if what matters to you is pain, is that you can say 19 out of 20 patients the pain goes away. However, 4 out of 10 patients, their general health is no better or worse, and very disturbingly, 3 out of 10 patients, their general health is worse. Now, if we're doing truly informed consent, how do most practitioners consent patients in the USA? Because it would appear that they can't.
Well, that's the kind of information that we use, but I would say your point about 70% are collected for knee replacements. In my opinion, that's too late. You want that information to help that patient make a decision whether knee replacement is appropriate or not after they've had their knee replacement or after they've decided to have their knee replacement. It needs to be at the first encounter, and that for us is the triage criteria. So just like in some practices, the team won't see you until you've had your x-ray. We won't see them until we have that information so we can know what their preferences and values are, what their baseline health is, and what they're trying to achieve out of this visit.
Eric, did you want to make a comment?
No, I think that's exactly it. Sometimes the outcome the patient wants doesn't have much to do with a procedure, a medical procedure. It might have a great deal more to do with, are they lonely? Is their hearing bad? Are they depressed? And treating those things would create a far better outcome in many cases.
Well, gentlemen, I just want to thank you so much for joining us at the Roundtable discussion here at the Value-Based Care Conference in Newport. Thank you, Top Med Talk, for supporting us, and we will hopefully have a wonderful rest of our conference. Yeah, thank you so much.
Thank you.
Enjoyed the
Pleasure.
discussion.
Nate Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.